Thank you. Um, so, continuing with the program, we have uh, one of the keynotes here, and a really distinguished person here. And you can read his full bio, but I'm going to just introduce a little bit. Dr. Konstantin Alferis, he has an MD, and he also from a school of medicine in Greece, and then he also has an MS and PhD in medical informatics and intelligent systems. And he has, as I said, he's been at a number of institutions, but I'm going to focus on since when he has been at the university. He joined the University of Minnesota in 2015 as the Chief Research Informatics Officer and Director of the Institute for Health Informatics, which he continues to head. It's a university-wide entity that homes 24 core and 60 affiliate faculty. So it has a big footprint and a lot of faculty who work in healthcare and informatics across the university are part of his institute. He has, again, in terms of a number of things, I would say that among the different recognitions he's received, he served on advisor to many large NIH and university grants and corporations and Ministry Department of Health, as well as the US EPA. So without any further ado, let's have Dr. Alferis.
So, thank you very much for the introduction, and thank you all for coming today to this presentation. And of course, I want to extend my appreciation for the organizers of this wonderful event, the Data Science Initiative and the AI Health Institute, for giving the opportunity to present this talk today, which is centered on the concepts of responsible AI, technical rigor, trust, and adoption. And let me first start with disclosures and sources. I'm receiving federal funding for research from the listed grants. I don't have any commercial interest to disclose. The primary sources for what I'm going to share with you today can be traced back to a recent volume on best practices and pitfalls in healthcare and health AI that we edited and wrote the biggest part with George Simon and a number of other distinguished colleagues. This is the first work of this kind. It's 800 pages covering 400 codified best practices and pitfalls. And it has, since it was published by Springer Nature in 2024, it has gained some interest. It has 200,000 downloads since that time. Also, there is some work I've done with Bill Stead of Vanderbilt University that parts of it I'm going to discuss today. So I think we can all share the assessment and the feeling that artificial intelligence in health sciences and healthcare, including as part of AI, machine learning, has right now truly remarkable capabilities, and these are across many tasks and types of problem solving, including predictive, AI, causal, generative, natural language processing and understanding, and many more. Now, many people were surprised that in 2024 there were 2 Nobel Prizes linked to AI work. I'm surprised that they didn't know of the ones that preceded those. So there were actually 12 Nobel laureates and 12 Turing Award recipients, which is the Nobel Prize in Computer Science, whose work was directly contributing to AI advances or was using AI to make very substantial scientific discoveries since the 1950s. There is a very vast literature on AI and machine learning, estimated between 3 and 6 million in Google Scholar. 250,000 papers are in PubMed that focus on health. And there is, as we all know, incredible interest and public awareness and huge investment that's happening in our times. Now, the problem that we still have is that the majority of clinical AI is proof of concept. It's preclinical, has not been adopted clinically for the majority of efforts, projects, tasks, and clinical areas. There is a literature of why this happens. There are many reasons reported, such as lack of generalizability, lack of clinical trials or other clinical testing, lack of adherence to reporting and other guidelines, implementation factors, that conditions for performance of AI are not met in practice. And at the end of the day, there's a very long and rich history that has AI successes, but also, equally importantly, there is a long history of AI failures and AI winters. And this has created a lack of trust for the translation and adoption of the clinical domains. The main thesis of this presentation is rigor in designing, validating, developing, and deploying clinical AI is essential for knowing the properties of AI systems and models. These can create assurances for effectiveness, safety, ethics, and so forth that lead to trust and that leads to adoption and clinical value. So that's the chain of, of factors here. And Billstead and I have created this. We try to summarize this and say, look, there's a virtuous path to clinical AI, and there is a vicious path to clinical AI. And let's start from the vicious path first. So if you start from non-scientific factors, for example, heuristics, various cognitive biases, strong marketing by commercial entities, you get non-scientific assurances. And this creates one of two things. One is a path that goes through unwarranted trust to false promises and harm to patients and system of care. And the other path goes to having no trust. And then you have no deployment and opportunity costs. That's the vicious path. The virtuous path starts from rigorous scientific properties, both theoretical and empirical, as I'm going to discuss in a minute. And that creates scientific assurances, scientifically warranted trust, adoption, and value generation. Now, what is rigor? NIH defines rigor as the strict application of the scientific method for unbiased, well-controlled experimental design, methodology, analysis, interpretation, reporting, and of course, reproducibility. And if science isn't rigorous, it's reckless, says one of the documents that the NIH has published. And of course, the same is true for AI technology, which is the applied science. Now, why rigor is needed, you may ask? Well, as I said, there is a long history of AI winters, which are large-scale AI failures in the United States, the United Kingdom, Japan, and other places in the 1980s and 1990s that led to the implosion of many AI companies, research programs in academia, investment, research funding for both commercial and academic entities, loss of credibility, and so forth. Associated with that is the AI hype problem, and of course, this is not confined, unfortunately, to the 1980 to 2000, but it has happened also since 2005 and today on a large scale. Now, Gartner is famous for describing some problems related to hype. There's a lot of optimism at the beginning. It's not justified by scientific evidence. Then it crashes, and we have disillusionment, and people do not believe anything. And then there is a gradual convergence to the true capabilities of the and value of the technology, which is the plateau of real value. If we look at this a little bit more carefully, I think there is a spectrum of, on one end of the spectrum, we have the minimum possible performance on some specific task by an AI system. On the other end of the spectrum, the maximum possible capabilities and performance, and this can be established mathematically in many cases, as we will discuss. And then there are 3 points of particular interest. What is the true current capability of the AI systems? What is the minimum required capability to solve a clinical problem or to advance the standard of care and outcomes? And what are the promised capabilities? And the distance between the current capabilities and the promised is the amount of hype that we have. And the problem, the situation becomes really dangerous when the actual minimum required capabilities are above the current capabilities, because that creates the opportunity for hurting patients in the system of care. Now, I want to contrast this, what we're doing with current medical and health AI, with medical statistics. Why? Because most people in health sciences and healthcare are very familiar with essential statistical concepts. So if someone says, okay, I want to do something very basic in statistics, like build a regression model. I'm going to, for example, regress the weight of someone, of an individual, as a function of their height. Now, medical statistics has a number of safeguards and testable conditions around fitting a model like this. So that the relationships must be linear with the output, or that we have interaction terms, that there is homoscedasticity, independent errors of observations, identically distributed observations, sufficient sample size, and so forth. So there's a whole bunch of testable conditions mathematically guaranteeing that this model is going to work as expected. Similarly, mathematical statistics gives us the tools to control errors. We're all familiar with the p-value. What's the p-value? It's the probability that a relationship or difference will be declared true when it's not true, and that's a false positive risk. So the p-value and the threshold, which is the alpha, controls this error. And the other side of this is the power, which is the probability that a true relationship will be discovered, and 1 minus power is the false negative risk. So, and here's the aha moment for many people, and I have discussions with researchers and clinicians and others. Excuse me. Do we have such knowledge about both older and very new AI system? Do we have the knowledge that says under these testable conditions, the AI is going to work well, it's going to be safe, it's going to be effective, it's going to be ethical, and so forth? And do we practice that? So this is somewhat rhetorical, because in reality, the current state of AI is the following. We have 3 categories. The first category is methods with extensively known theoretical properties and guarantees, especially in predictive modeling and statistical machine learning, but also in formal causal graph induction theories and other theories of causality. The second category is methods with partially known properties. So, for example, I'll give a very simple example. For deep learning or artificial neural networks, we have universal approximator theorems. They say that these things can learn any function under some conditions, but then we don't know important aspects of this, like how fast they converge to the true data generating function that we want to model as a function of sample size, for example. This is largely unknown across a range of real-life problems. And then we have the third category, which is systems and methods with largely unknown properties for common tasks, such as prediction, causal discovery, and so forth. And they are used heuristically, which means we just use them and hope for the best. And that's where we are. So it's a very uneven landscape. And the question is, how can we move from where we are today to where medical statistics is, to make it more scientific, more controllable in terms of risk management and capturing the value? And the problem is that many people talk about AI as if it's a single thing. There are hundreds of families of methods doing dozens of different tasks, and yet people say AI can do this, AI cannot do that. Which AI? I mean, this is just a statement that's completely vacuous unless you really specify what we're talking about. There are many recent examples, as I said before, of AI falling short. 2 very recent papers, the D-Explain, which is, I don't know how many of you know it. It's a derivative of the internet system of the early 1980s. Internet was developed at the University of Pittsburgh. D-Explain was developed at Harvard. These diagnostic systems from the 1980s are performing so much better than the latest large language models, for example. And there are publications that show this. Vanderbilt University published a paper very recently where they compared very vanilla boosting machine learning for several clinical tasks with the latest tuned and non-tuned large language models, and the comparison was just like incredible. We're talking about AUC 0.85 or higher for vanilla machine learning compared to 0.55 for large language models, which is like randomly flipping coins, essentially. There are many other problems, like with COVID modeling, with sepsis models, with resource allocation models, the famous Optum models, with causality, with length of stay modeling, with translating among sites, with translating among tasks. There are more than 300 published studies that compare, say, vanilla statistics like logistic regression with various forms of machine learning, including the best of deep learning, on average and across the board. Unfortunately, the news is that classical statistics outperforms the latest machine learning in many, many cases, in the majority of cases, actually. And why is that? Because of sample size issues and other issues that have to do with how these models are developed and so forth. So for an extensive analysis and literature supporting this and fleshing this out, see the 12th chapter in the book that I mentioned before. By the way, the book is open access. Everybody can download it for free. You don't need to spend any single dime to have access to it. So let's see the solution to these things. So theoretical properties. So theoretical properties are facts that we know about AI systems and models and methods families that are described in the form of mathematics and mathematical theorems that say under these 10 stable conditions, you can expect this kind of problem-solving performance. And there are many of these properties. Probably the most well-known ones are the computability, the expressive power of computer models, the soundness, the decidability if they're doing deductive inferences, rule-based inferences, etc. Tractability, of course, in terms of compute time and sample size, transparency and explainability, and many, many more. Okay, so there's a whole bunch of important properties. And then there is empirical properties. And empirical properties is what we go out in real world and we measure, and we can measure a number of things using three lenses. One is the evaluation, the other validation, the third verification, the EVV. So evaluation is the error or other measurable operating characteristic. Validation refers to meeting user needs. And the verification is meeting design requirements. And of course, these are structured in progressive levels of hardness, starting from very well-controlled artificial data all the way to resimulated data, to real data with known answers, real data with unknown answers, and so forth and so on. Now, there are two fallacies that I would like to bring to your attention, very important for the message of this talk, which is, the first fallacy says, oh, we can skip theory. We just do some clinical trials, see that something works. It's all good. That's the clinical trial sufficiency fallacy. And the second one is that, oh, the computer science view of things, I'll prove everything mathematically, I'll do some, minor empirical testing in the lab, and it's gonna work just fine, in real life. That's not, unfortunately, both of them are false, which entails actually that we need to apply both. We need to know the theory and the theoretical properties, and we need to know the empirical properties. Why? 5 reasons. Number 1, if you don't have the theory, you haven't de-risked the AI model before it's applied on actual human beings, similar to rational drug device, to medical device development, so forth. So it's unethical. The second one is, it's not even clear what factors to study in a clinical trial or other empirical study and use as covariate in the analysis and so forth and so on, unless you have a theory about what you need to measure and how. Third, the empirical studies can cover only a very limited number of situations, okay? Whereas mathematics can cover infinite situations very easily. The fourth one is that with empirical studies, now we go to the other side, the advantage of empirical studies. You can measure downstream and system-level effects that are very, very, very hard to model on paper, with pen, with mathematics. And finally, empirical studies can also test what? How good are the assumptions of the theory, whether it matches the real-world conditions. So they can look at the alignment of the mathematical underlying theory with the real world. Now, how do we communicate? How do we enforce rigor? One great way is through adoption of the appropriate reporting standards. What's a reporting standard? Highly memorable example, in my opinion, is this. So you go through a bridge. There's a sign there that says this bridge is guaranteed and tested to hold up to this static load, okay, like 7.5 tons in this example. If you go over this, something really bad is going to happen, okay? So that's a reporting standard that the Department of Motor Vehicles or whomever has adopted that says you need to establish what are the safety parameters and safety guardrails for bridges, for example. The same is true, by the way, for everything, okay? Buildings, devices, electronics, electrical device, everything. So how do we translate this concept to AI? Well, there is a ton of reporting standards in general health science. And the Equator is an organization that manages these reporting guidelines, contains more than 250 reporting standards. That's this consortium. I highly recommend just visiting and getting familiar if you're not already. And they cover different things, including predictive modeling, AI complex modeling. What these do, they say to people, look, disclose what you did about all of these different things that can affect your outcomes, your safety, and so on. If you are a reviewer, just seek to see what these disclosures are. And so on. So they don't tell you how to do the research, but they say you have to disclose what happened here and transparently. And there are many complex model reporting standards. And if you go to, again, the book, the favorite book of the day, you will see several of them, and you will see their analysis comparatively. And at the end of the story, they're all incomplete. Okay, so there's no complete standard. But there's something else that can be also an extremely powerful alternative or adjacent to this, which is something that looks like the labels that the FDA is, is managing. So the FDA prescription labels for prescription drugs, which is slightly different than off the counter, is basically disclosure that pharmas, drug manufacturers, have to do about what is the purpose of the drug, who should take it, who should not take it, at what dosage, what are the adverse events, everything that, all the critical things you need to know about safe clinical application, they are disclosed, and manufacturers are, in order to be compliant with the law, they have to make these disclosures and they're accountable. And the same concept has been translated to machine learning models through two different varieties. One is the AI model label, the other one is the AI model card. The card is a little bit broader and it's more ethics oriented. So, but the AI model by Sendak and colleagues really gets to the clinical application. When this particular model is supposed to work well, how can it be entrusted, in what kind of clinical tasks, how it was developed, how it was validated, and so forth and so on. And a very similar concept has been pioneered by George Simon and myself in methods labels. So we have created methods labels for all major AI and machine learning methods used in health. And basically, it's the same concept. What are the theoretical and empirical known properties of AI methods that are used to construct models and systems? And you can see many instantiated examples of this in the book. So, in conclusion, rigor in clinical AI is not some kind of academic luxury. It's an essential ingredient for its success. Unless we have the highest levels of rigor, then it's not going to be trusted, it's not going to be adopted, it's not going to bring value to the clinical domain, the patients, and all constituents. The chain that needs to be particularly remembered is rigor leads to good properties, which produce scientific assurances, which creates trust, which creates adoption, which leads to clinical value. Now, this is a very fragile chain. If any of these links breaks, then the whole thing gets disrupted. So it doesn't have too much redundancy or alternative paths around it, so it needs to be carefully followed. So this is the conclusion of this presentation. Thank you very much for being here, and I look forward to your feedback and questions.
So I love the idea of this sort of AI prescription label. And I think that it's a great thing, for example, researchers to start integrating into their own research sort of voluntarily. But if you wanted to standardize this and ask, so for example, large-scale companies to use this as well, how would you go about doing that short of getting it passed as some kind of law or requirement? As far as I know, there's not like an FDA for AI models. So how would you go about doing that?
So thank you for your question. First, there are two domains here. One's the health research, and the other one's clinical. And for health research, I totally agree with you. Voluntary, especially in this time, in this stage of the game, is the way to go. For example, in the Senate consortium, which is an NIH consortium with more than 20 major universities participating, studying cellular senescence, my team and I have been entrusted to develop good modeling practices across the consortium. And our approach has been completely participatory, voluntary, not create straitjackets around people's activities, and making it exactly as you described. Now, in the clinical domain, where there are high risks and people can be hurt seriously by systems that give false advice, et cetera, especially for major diseases and dangerous treatments, and also errors of omission and opportunity costs, which are worse in many ways because they're invisible. You never see them because they're counterfactual, essentially, in reality. But you can anticipate and know that they exist. So I think there we need legislation and regulatory enforcement. For example, for the off-the-counter labels, these are completely voluntary, right, by pharmas. But when there's prescription drugs, which supposedly is a different set of drugs, why? Because they're more dangerous, right? And then they are, in order to be compliant with the law and to, exist in the market as a provider of this drug or manufacturer, you have to provide these labels and you're accountable for their content. So I think we need very similar things in AI, and not in the far future. We need it today, actually, in my opinion.
I think, we can move on to the next set of events. Okay, so thank you.
Thank you.